Good afternoon, everybody. My name is Vincent Connolly. I'm Clinical Director with the Emergency Care Intensive Support Team. I work with the Intensive Support Team 2 days per week, and I'm an acute physician based up in Middlesbrough for the rest of the time, and I do weekends and 12-hour shifts and all the rest of it. So I kind of get hands-on experience at the coalface and also the kind of pleasure of being able to go around lots of other trusts and healthcare communities in the country to see what's going on. And on one of the post-8 ward rounds one day, there was an interesting medical case that kind of was very similar to a case that was in-house. And we were discussing this in the ward round, and the junior doctor said to me, she said, "Dr Connolly, you're our Dr House." And I just couldn't decide if she was being sarcastic or not. That was the curious thing about it. Righty. This is Oscar. Oscar is just over 2 now. So what personality trait would we associate with Oscar? A dog? He's a dog. What do we associate with them? He could have. He is getting ready for the hot weather. But usually with dogs, what human trait we transfer onto them is one of, well, loyalty, yeah? Loyalty. And the first bit of this talk is really kind of just some very general reflections on things I think are important in understanding how senior medical staff work. And loyalty is key. Most consultants in an acute trust will have been appointed by the senior doc in the department. Most of them will feel a degree of loyalty. Even if they don't approve of everything they do, they'll feel a degree of loyalty. They will, outside of work, shared a variety of personal experiences, supported each other during a variety of things. They might work together for 10, 20 years. So there's a tremendous loyalty to your clinical colleagues in healthcare organisations. What's the average lifespan of a chief exec in NHS England? 2 to 3 years. So given the choice, given all other things being roughly equal, given the choice, where are most consultants loyal, where are most senior clinicians' loyalty is going to lie in terms of making a decision? They're really going to lie with their colleagues. And I often see going into organisations and talking to them about changing the way they're working, that one of them is often kind of talking for the rest of them. And they'll be reluctant and they'll be nervous about speaking up against that individual or contradicting them as well. There was a mention about the consultant contract, and time is everything in the consultant contract. That's how consultants are paid, by time. You could work in a DGH that admits 15 emergency admissions per day, or you could work with me in Middlesbrough where our 85th centile is 77 emergency admissions per day, or you could go to Nottingham where it's 120. You still get paid the same rate, and we haven't nailed down rewarding efficiency and effectiveness and productivity particularly well. So conversations with consultants often revert back to time. I don't have the time to do it, or I'd like to do it, but I don't have the time, etc. So I think that's an important consideration in discussions as well. Lots of things drive consultants barmy. It ranges from colleague to colleague. It can be, other colleagues. If you're a physician, it can be surgeons. I was working with a surgical colleague recently, and he was talking about ambulatory emergency care coming into his organisation, and he said, "These physicians, they've ruined my working life for the last 20 years, but since ambulatory care's come along, at least they know when to turn up and who to see." So you can tell what's driven him mad. So there's a lot of things that wind up, and some of it's mythology and some of it needs breaking down and all the rest of it. For me, this is one of the key drivers in what is motivating consultants. And I think the question was asked of Russell this morning, and it's the tension between being a generalist and being a specialist. Our organisations, whether it's your hospital, whether it's your Royal College, whatever, puts tremendous store by how specialist you are. So if you're a general physician, okay. If you're a gastroenterologist, well, that's a bit better. If you're a gastroenterologist that specialises in doing ERCP, then that's higher still. And so there's degrees of specialisation and subspecialisation, and our systems really reward super specialisation. And there's a big drive for physicians and surgeons to look and to become more specialist. And behind it, for me, that leaves a big vacuum in care that we need generalists to fill. Actually, what the health service needs at the moment isn't more specialists, it's more generalists to do the day job. It's people to see and assess the sick, unselected medical take in A&E and acute assessment units. But at the moment, we're driving people away from it because it's perceived as difficult, unpleasant, unsocial hours. And I can go and do this work 9 to 5, and everyone will think I'm wonderful because I'm such a specialist. We've heard a little bit in some of the presentations about variation. And of course, being clinical staff, we all assume we all deliver the best medical care at all times. But unfortunately, nearly every study that looks at it shows huge variation. Variation to the extent that we cannot all be right. And this is actually data from Dublin. It's looking at what consultants' test requests are in a post-take ward round. So you'll see there in the top right-hand panel that the requests for investigations range about 3 to 4-fold on a post-take ward round, whether it's CT, plain radiology, DVT investigations, etc. Now, 3 to 4-fold variation cannot be people that are following prescribed guidelines, people that are following recommendations of NICE, etc., etc. There is huge variation in what we do and how we practice as consultants. And if the sharp-eyed will have spotted the the GI investigations, a 15-fold variation in requests. I bet you the junior doctors know when that consultant's on to have all the referral slips for endoscopy ready just to make their life a bit easier. Righty. This is a refrain you'll hear a lot from medical staff, which is the M&Ms, managers and meetings. The kind of frustration when you've got to make sure that meetings that clinical staff are invited to are really worthwhile. And my personal experience of this is establishing ambulatory care locally in Middlesbrough. And the discussions got overtaken really by money and tariff and all the rest of it. And eventually what we said is, can the clinicians sit down, primary care, secondary care, and agree the pathway? And once we've decided what the pathway is, the challenge then is design a tariff and a system that will deliver that pathway. And actually, taking that model, it kept us out of the frustrating bit of listening to stuff we didn't really want to listen to. But it ended up with a win-win in that a tariff was agreed that actually benefited both the PCT and the acute trust. Now, on the blank cigarette packet of emergency care, this is my warning, which is that there isn't a silver bullet out there that is going to resolve all the problems of emergency care. And the term wicked problems was coined really to describe complex social, national or international problems that don't really have a solution. It was coined for things like immigration, Middle East, and maybe the application to emergency care in this context isn't quite of that scale. But the idea is that there are things that we can do that make it better, but they aren't going to solve all the problems, and we're going to have to revisit it. And how we see the problem and how we frame it really very much depends on where we stand and look at it from. And whether we're an economist, a social worker, a GP, a consultant in A&E, or whatever, we bring very different views to it. And therefore, if you ask those individuals, their solutions will be quite different as well. Someone sent me a paper last night about social isolation, loneliness and mortality. So a completely different perspective on if you want to make an impact on mortality, where you might want to invest some health and social care funds. So I think that's just a really important concept to bear in mind. Now, the next few slides are about tactics for consultant engagement, but they're listed in the reverse order of how I would carry these out. Because the last one is to do this, is to take the GMC guidance of the duties of a doctor and thrust it under the consultant's nose and say, do you know that point 4, you're supposed to demonstrate effective team working and leadership? That generally doesn't work in terms of engagement. You might get their intention for a spell, but I don't think they'll buy into what it is you're trying to sell them. However, on occasion, this has to be done. And on occasion, tactically, it's worth, bringing up at meetings from time to time, just, that the GMC have recognised the importance of team working and leadership. Because in some of the sites we visit, these can be big problems working with toxic teams. The next the next threatening option after that is the medical director. So, to sit on the naughty step outside the medical director's office to have a challenging discussion about your clinical performance and your attitude to working with colleagues, again, should be a long way down the line of how we progress it. And where we work in organisations, where we've seen the medical director hands-on involved in the improvement work that we're involved with at the Acute Trust, we can often see really rapid engagement, really rapid changes in some of those organisations. And, just seeing who's involved at an exec level is really valuable. I suppose my concern for medical directors, particularly in acute trusts, is the weight of revalidation and how that's going to impact on their time. And there's an estimate of the order of 10% of senior clinicians will have an issue at this point of revalidation. And of course, it's going to fall to the medical director's office to sort that out and manage it. So I think I'm concerned about the time that they'll then have for improvement type of work that we're really keen on. Of course, the great and the good of the colleges and societies all have a variety of guidelines, and we consultants will choose to pick out the ones that we think reinforce our predetermined biases and beliefs and ignore the ones that we don't like as well. But by and large, if you look through the Royal College of Physicians, Society for Acute Medicine, College of Emergency Medicine, it's all there saying 7-day working, 12-hour cover, they all support it, and right down to a T. And I was in a trust recently, not too far away from here, where a consultant was talking about a recruitment strategy not to talk about 7-day working, because we wouldn't attract anybody if we talked about 7-day working. So let's just advertise for someone for 5-day working. Well, what kind of a problem is that storing up for you further down the line, if you're going to recruit on that basis? And actually, a lot of the acute physicians and a lot of the enthusiasts know that this is coming. They know, and some of them are going to their trusts and saying, why haven't we got 7-day working? And they're pushing hard for it. I think it's important to be clear what you mean by 7-day working as well, because a number of places think that 7-day working is getting a consultant in for 7 days. And that's, in my book, that's not what it's about. 7-day working is about having the infrastructure and support to deliver the same care Saturday and Sunday that you do Monday and Tuesday as well. And nowhere I know does 7-day working of that concept. A lot of them will do enhanced weekend working, as I would frame it at the moment. Okay, carrots and sticks. Carrots and sticks, incentives for change in practice. How good are they? How effective are they? Do you think they're really good? What's one of the biggest carrots that we dangle in front of consultants if there's a problem with elective working and we can't deliver 18 weeks? What do? We give waiting list initiative rates, and we pay people beyond premium rates to do extra sessions to meet a waiting list and meet a target. And very rarely do you see that waiting list initiative money going down in organisations. It becomes the way of resolving the problem instead of redesigning the system. And carrots and sticks of that type don't really work. And no less a believer in true capitalism than the Federal Reserve Bank commissioned a study which said, but once, and these were studies where they gave people financial incentives to solve problems or to do tasks, but once the task called for even rudimentary cognitive skill, a larger reward led to poorer performance, which is, in many people's eyes, completely counterintuitive. But if we're practicing evidence-based, that's where the evidence is. And you might look at that and say, well, rudimentary cognitive skill, well, perhaps it'll work in orthopedics. But I'll leave that for you to think on. So what is it? What are the things that really engage people and really get them up in the morning to do stuff? Well, one of my hobbies is to do a bit of fell running, and people look at me in kind of abject horror and say, why on earth do you enjoy that? What do you possibly get from doing this kind of activity? And it certainly isn't, money, power and glory. This is the furthest south we go in this. Does anybody in this audience know who Joss Naylor is? No. There was about 3 people when I did this further up north. Right, Joss Naylor is in the list of the 100 most influential British sporting personalities in the UK, but it's obviously the 100 most important people that you've never heard of. And he's a well-known fell runner in the lakes. And his point about this, I'll just quote the bottom bit of this, is if you get it right, there is a point on an event like this where you're just running on a high, and even after 60 to 80 miles, you can still feel that it's fantastic and it's just brilliant. And he's not got any, there's no world championships, Olympics, there's no money, minimal sponsorship. It's certainly not for the recognition of people around the UK by the looks of it either. It's something that he loves and he wants to do and he's passionate about. And, talking about him, he recently completed an event in the lakes of doing 70 peaks in less than 24 hours. And he chose 70 peaks because it was to celebrate his 70th birthday. Not all old age results in coming into hospital. So getting people to engage with our discussions, this is what we sell to people. We sell to them remodelling emergency care on delivering an ideal care model around linking quality with safety, flow, and reliability of care, and the 7 no's and the pursuing of perfection. I would say that if senior clinical staff don't engage in this level, they have got a serious problem with why they come into work. But most people are interested in engaging in that basis. And the other thing about engaging people is how we talk about stuff and how we communicate what it is we want to do. And one of the big challenges in acute and emergency medicine is recruitment. But you can go to some places and they can recruit, no problem at all. So South Manchester, North Tyneside advertise for acute physicians. They get so many applicants, they turn people away. And yet there are lots of places locally, around in London and elsewhere in the UK, they either don't get high enough quality applicants to have an interview, or they sometimes appointing people that aren't really acute physicians or emergency medicine docs. And I think some of it comes down to this, which is how the discussion happens around engagement with clinical staff. Because what we tend to do is talk about the what, a bit about the how and not much about the why. So we say we're a well-recognised emergency centre in London. We're affiliated to a university. We've got a great A&E, and we'd really like you to come and work in our department. As a kind of process of thinking that goes into it. What some of these other organisations have done, and they're recruiting people to work 7 days, making sure shifts in the units are covered 15 hours a day. What they're saying is saying, we believe in delivering fantastic emergency care. And we believe that to do that, we need senior doctors in the hospital 7 days a week to support emergency care. And we can fulfill your professional ambitions as well. Why don't you come and work with us? And it turns it all round in its head, and it all sounds quite different when we talk about the why we want to do something rather than what it is we want to do. Okay, here's a graph, a blue line and a red line. And this graph is comparing two organisations that set off to produce a similar product. One of the organisations, when I mention the names, you'll know who they are, but one of the organisations is a household name, makes so much money that when it decided to make this product, it could throw everything at it. There was nothing it couldn't throw at producing this product. It could hire the very best of people. It could give them access to the very best of resources. It could, have people manage the project fantastically well. So there was nothing, and everything that was put in place is what any leader, manager, economist would say was a super approach to developing this product. The other said, we're all in this room together, and everyone in this room has a degree of expertise, and we would like you to play an important part in developing our product. If you're not really interested and you don't buy into the concept, we don't have a problem with that. Don't bother. But if you are interested, we'd really like to speak to you to talk about what you could do and contribute to making this product. Does anybody use Microsoft Encarta? No. Does anyone use Wikipedia? So which one? So you can guess now which one's which. So, an approach around passion and engagement and so on, delivering extraordinary results in the face of conventional advice about how to tackle a problem. One of the other things to remember, although this you'll be very familiar with this, and the tipping point at around 17 or 18% for adoption, is to remember that a lot of clinical colleagues move around in this. And, I come across people that are very resistant to change in aspects of what they do. So they might say, we are not, I don't believe that consultants should be in 7 days a week. I don't think it adds much value to process. The registrars are pretty good and they've got a good handle on it. But they might be right at this end when it comes to adopting a new treatment or a new technique in their specialty as well. And I think it's just important to bear in mind that, you can't pin somebody somewhere in the curve and that they can move around. So intrinsic motivation is made up of these. These are the things to look for in individuals. They'll want to have a degree of autonomy. They want to be able to be self-directed. They don't particularly appreciate being micromanaged. So we need to give them some of that. They will want to be the best they can be in that circumstance. So they'll look to you to give them that opportunity to train and hone and refine their skills. And we need their purpose, why they get up every day to do the job, to align to organisational purposes as well and do that. And for me, they're the three things to really look for and get engaged in. One of the things about working as a consultant is, as well, and I'm sure this applies in lots of others, the kind of thinking time that we have to do stuff. And again, if you look outside of health, you see different examples. So Google allow their staff to spend 20% of their time, so that would be 1 day of a working week, to work on projects and things that they think are worthwhile, that they think will improve. And out of that, they've had a number of products that we use, like Gmail has come from that. So 50% of their new products are coming from letting employees think and work on their own projects. And there was an organisation, an Australian engineering company, that did something very similar. It was said they've got to come back the next day and present it. They can go and work on something and of their choice, and it's really motivating, it's really stimulating. But the organisation, and that would translate for us into patient care, really get something out of it. As the intensive support team, we get a lot of this, which is all the reasons why not to do stuff. We can't do it because, we're a big teaching hospital, and, we've got a liver unit, and that skews all our emergency admission data. We can't do it because we're a small rural organisation. Our patients have got to travel further to get there, so we can't discharge them. We can't do it because we're urban. We can't do it because we're rural, because we're south coast. One teaching hospital said they couldn't do it because the university was next door, so a lot of young people came to the A&E, which even I couldn't even figure out what the thinking was behind that one. If you group health organisations, whichever way you cut it, if you group them into similar types, there is still huge variation, which means there's scope for improvement and scope to get better. So I don't buy into any of those. There are some occasional special cause variations that you might accept, but by and large, most of these are prefabricated excuses of, to justify not changing, and they're quite common. The other thing we do in health is blame all our partners. So for delayed transfers of care, social services, every single time, social services. Our own data shows 3/4 of delayed transfers of care are NHS delayed transfers of care. So blaming social services is a bit of an error. But the thing at the bottom here, and the one thing that gets me wound up, is blaming the patient, because a lot of people do that. Oh, the patient's too old and too complex. They've got too many illnesses for us to manage with them now. We can't cope with it. We can't deal with the complexity of the frail elderly. And for me, that's a big problem, because I think doctors that say that need to really have a good long look at themselves about, whether they're really up for the job, because this is going to be the bread and butter group of adult emergency care in the future, and we all need to be skilled at looking after the complex, frail elderly. So listen, learn and lead. Think about, sometimes I'm interested in the concept of legacy, because most senior clinicians, are passionate about what they do, and they want to leave behind them something that they think was worthwhile. They want to leave thinking things are considerably better for this service than when I started off. But occasionally we go into organisations and they'll talk about Dr. So-and-so, and that's just the way he does it, but it's all right, he's retiring in 5 years. Yeah, fine. So we're just going to let it drift on for 5 years like this. And at his retirement party, there's people out the back going, yes, it's going at last. And now we can do something. That's just not really acceptable. Whereas sometimes you get people, I've bumped into people retiring saying, oh yeah, I'm finishing up, but you know what they've had to do? They've had to employ 2 people to replace me because of the work I've done in the trust over the years. Really proud of what they've done, and that's what we should be really fostering and promoting as well. My holy trinity is, if you can line up a medic, a nurse, and a senior manager working closely together, really, there's not much that they can't do, there's not much they can't achieve if you get that well lined up together and get them working well together. And then just a final quote before we kind of open up to discussion. This is an observation of how Wikipedia works, and it's kind of thinking about Jimmy Wales' idea and how he set it all off. And you've got people all over the world contributing to this product, but something that's much greater than any individual could do, because of the way it is of people working together to produce such a fantastic product that, we all use it every day.